All right, well, I'm really excited to introduce Dr. Hoffman. Dr. Hoffman is professor of OBGYN at the Thomas Jefferson University and chair of the Department of Obstetrics and Gynecology at Christiana Health. He's published over 90 articles, including the aspirin trial, which was published in The Lancet in 2020, that randomized nearly 12,000 women to low-income countries. Women in low-income countries, and showed that low aspirin dose decreases the rate of preterm birth, preeclampsia, and perinatal mortality. So Dr. Hoffman and I met at a meeting that was discussing remote patient monitoring. And as you know, UAB has an active remote patient monitoring program. And we've been working with Dr. Sinke, Dr. Batterby, and Dr. Tita on how we can expand remote patient monitoring in both the prepartum and postpartum stage. And so I was fascinated to hear with what Dr. Hoffman had already done, and just really excited to, for us to learn about all of the work that he's done in remote patient monitoring and this space.
Thank you, Eric. It's my pleasure. And again, this sort of feels like old home week, having worked with many of the folks at UAB before. What Eric didn't share with you is that we were both asked to do this, what's called a pechakucha. I didn't know what a pechakucha was. It's a Japanese tradition of storytelling. We're only allowed to use pictures and not words or p-values. This lecture will have p-values, it will have data, but it will also represent a little bit of some of the pechakucha style, because it really is about a story and a journey and talking about where we've gone through. So just to talk quickly in terms of learning objectives, I'll just briefly review digital integration of pregnant women in the quote-unquote digital divide. I think many of us are concerned that these opportunities are not real to our patients because of the lack of technology and resources. Excuse me. I'll talk about a number of different approaches to social determinants of health and a new way that we're approaching it from our standpoint in Christiana. And that'll examine some very specific use cases in obstetrics in terms of monitoring, and where we've been able to at least close part of the gap in terms of racial disparities. Just as a quick disclosure, I will mention the aspirin trial. I did receive some funding for that. We'll talk a little bit about some of the efforts that we have locally to increase the utilization and compliance around aspirin. So just a brief overview. I'll talk a little bit about the brief history of prenatal care, talk about some of the challenges that we have in obstetrics. And I think, as you were hearing earlier, our challenges are growing, talking about digital engagement, and then talk about specifically how we're rethinking about prenatal care through texting, an app, and care management. And I'll give some specific examples. And then I'll talk a little bit about kind of what we're thinking next in terms of next steps. So our journey begins about 5 years ago. And although this is a picture of our new center, what was interesting about my board who decided to fund our new center is that they also asked us not just to build a new building, new walls, new patient rooms, but also to think about how we deliver care. So as part of the funding for the building, they actually set aside a very large amount of money to address social determinants of health. And a lot of the call was to think about how do we work differently within our communities? How do we, in fact, erase some of the disparities that we see in our communities? So it's probably important to kind of start a little bit about where did we come from and what is the history of prenatal care? So this is a picture of London in 1905. And for those of you who don't know it, the first real model of prenatal care came out of a British medical commission, and they really centered around preeclampsia. And if you look at the roots of what is our model for prenatal care today, it is very much aligned with the model that was put out in 1905. I like to point out the fact that the Model T was developed in 1908. And I would suggest, in fact, that prenatal care has changed somewhat, but maybe not as much. And we don't drive Model Ts anymore. So I think that we need to figure out new ways to deal with complex issues and think about prenatal. Additionally, if you think about prenatal care, it is highly variable. One thing that is consistent is we measure blood pressures every visit, but prenatal education is really contingent upon the person that they're seeing. And the other challenge is it's really gotten to be much more complex. So when you think about it, the obstetrician is really placed at the center of coordinating a lot of complex problems, whether it be high blood pressure, preeclampsia, diabetes, genetics, lactation, nutrition, social determinants of health, fetal anomalies, etc. And the one thing that I've learned is I can't do with my people and say is just one more thing that I want to add to your 5-minute visit. The other point that I want to make is that we think about prenatal care and pregnancy through the lenses of our offices. The reality is that the majority of time of what's happening in a pregnancy happens outside of our walls. So I've done the math, and if you actually look at a woman who gets 12 visits, literally 99.9% of what encompasses a pregnancy from conception to a 40-week birth occurs outside, yet that's not a space that we have any window into. The other issue that I think is really important to shape is to think a little bit about maternal mortality. And I think many of us have had a call to action about the racial divide that we see within our country. But even if you opened up the current Gray Journal this month, what it points out very nicely in an article that looks at both Black-white differences, but looking at rurality, in fact, it is almost equally dangerous to live in a rural community. And if you pull out a lens even further and look at the broader world, in fact, if you look at the US rates, even though there's really stark differences between African-American and Caucasian women, if you go to countries like Pakistan or India, their rates are literally 10 to 14-fold what ours are from that perspective. The other point which I just want to make on this picture here is not me in the corner, but really this person here. This is what's called an ASHA. And ASHA is a healthcare worker. She's a member of the community. She lives in the community. And in fact, part of her job is to guide her through the complex network of healthcare on an ongoing basis throughout her pregnancy. This is literally somebody who delivers medications in the cases of our trials. We have worked with them in prior studies where we taught them how to take blood pressures. And then we delved down a little bit beyond the fabric of at least the Indian healthcare system. These people are really core to the way that they're able to deliver care effectively. Just as a contrast, India spends 2% of its GDP on healthcare versus we're narrowing in over 18%. So where we are in obstetrics in America, we have lots of challenges. So poverty, and if you use simply Medicaid enrollment as a marker of poverty, Medicaid pays for 45% of the births across the nation. It's no different in Delaware. When you pull the hood a little bit further back, what you see is that pregnancy is the #1 diagnosis and accounts for about 27% of Medicaid dollars. And I think we've all been challenged as we've practiced to recognize that our patients are not getting better, but getting sicker. The rate of obesity, chronic medical conditions, and racial disparities, at least in my career of 25 years, has only increased. Additionally, we are having a provider crisis. So over half of counties across the United States do not have an OBGYN. This is a study data that's about 2 years old, but it's currently projected that about 1 out of 5 US birth facilities are deemed to be at risk of closing. And when you look at the broader MD community, not specific to OB, about 1 in 4 of us are over the age of 65. And then the other part of it, and I'm sure UAB is in these negotiations either as well, that we're thinking and taking on more at-risk contracts. So thinking about how do we think about care differently to deliver value? How do we do more to take care of more complex patients with less resources? So my system has focused on this concept of radical convenience. How do we get so it's easier to do the right thing? And really thinking about the concept of digital engagement. Just to give you some data from Pew, 92% of women of childbearing ages have smartphones. The other point that I want to make is about 2/3 of women download a pregnancy app, and that we have an opportunity to develop consistent education and care standardization by thinking through these processes a little bit differently. So this is a Christiana care strategy, at least it's for obstetrics. So the first part about it is we want folks to be engaged. We want to be a part of their daily lives and help them to have the tools to manage themselves within the community and tie them to the resources, and not just the medical resources, but also the resources in terms of social determinants of health. On top of that, we're layering on patient-specific texting campaigns. So we recognize everybody's pregnancy journey is not the same. People are diabetic, people are hypertensive. Some women are having repeat sections, some are thinking about inductions of labor. So how do we layer in the individual components of what is a patient's journey and provide them with education, more than that 15 minutes where we have to complete our Cerner note as well as do the exam and deal with all of their complexities. And then finally thinking about that much of the care happens outside of the office, and how do I pass some of that work on to care management and thinking about it in an effective way. So this is sort of the first building block. And again, this actually comes out of India. I was traveling in northern India at a site that I think Wally has been to as well, in Nagpur, India. And there was a woman there who invented a pregnancy app where she was taking care of 7,000 pregnant villages of women using an app. And what I realized is in fact that we had an opportunity to think about it differently. And I had to argue with my CEO about why build another pregnancy app. What's wrong with what to expect while you're expecting? And by the way, if you've not read What to Expect While You're Expecting, it has been on the New York Times bestseller list for over 20 years. It was actually written by a nutritionist who has no obstetrical experience. And ironically, the part that she probably gets most wrong is nutrition. So what we decided to say is there is no local context or resources. So the woman is 2 in the morning who has nausea and vomiting, who needs to go get a script for an antiemetic, doesn't know where to go. And when you look, and this is data that comes out of New Mexico, where they looked at all of the apps that are available to pregnancy women, that almost all of them have commercial goals, that they're trying to sell something and had little input by medical professions. And in fact, when Nathan Blue did this, he found that only under 7% of the women, 7% of the apps actually had the tools that you needed to manage a pregnancy. So the conclusion that we came up with is that most pregnant women are digitally engaged and they're using tools that are clinically uninformed, and that we're not involved in these conversations. This started a lot of late night Googling and texting and thinking about it and reading books like What to Expect While You're Expecting. And what we decided to do is to build our own app. So this is our app. It's called the Pregnancy Care Coach. We have over 500 elements of content. And what we also did is we built the opportunity for a woman to build in her own care team. So she can actually say who her OBGYN is, pediatrician, MFM, pharmacy, as well as we included all of the social services within our community that's available to folks. And we actually embedded a separate project that we had begun, which is sort of open table for social services. So this is called Unite Delaware. And what we've actually been able to do is to link 77 community partners. And these folks range from everything from legal aid to housing, to food, to transportation. And patients are able to put in what their needs are and directly access it. And what the agency then does is pull who they can serve, and typically within 24 hours, get back to the patient. So let's just do a couple things that lets us understand what the social needs within our community are. It also lets us evaluate how effective the different agencies are in our community. And in fact, the largest use of this particular function has been our population. We also designed it with a coaching voice in mind, and then we worked it to build it into actually all of our employed providers at their first OB visit, with the goal of reaching about 1 in 4 of our obstetrical population. This is data, it's a little old. I have more updated data, but basically what you can see is we have increasing users month over month. And what we see is in fact, we're reaching folks about 10,000 times a month a year ago. These numbers have grown. And the part that we found really important and interesting is in fact, our average patient was going into our app twice a day. So unlike me, who gets to see a patient every 4 weeks, in fact, we were touching people literally twice a day on average across the course of their pregnancy. So moving on, just simply beyond the engagement platform of the app, we started to think through the concept about now how do we layer on the individual patient and the individual patient journey and tie it to the outcomes within our hospital. And again, building on this concept, so we really decided to focus on the postpartum woman. And what this picture is, and this is a picture of actually one of my partners, pregnant women are the busiest people on the planet. We complain about how busy we are. If you think about it, postpartum women really have a tremendous burden and are juggling tons of issues and complexities, in addition to dealing with not just their medical care, but also their children. By the way, I don't know who took this picture because I've been in that bathroom and there's no other room in there. And how she did it without drowning one of her children, I don't really want to know. The other part of this is we needed to recognize that we couldn't ask our providers to do one more thing. How do we keep our providers happy yet still do the work that we need to? And how do we think about care in a different way? So this is the old model that I grew up with. The patient calls, phones, faxes, or uses the portal to then reach out to the nurse and the doctor, and we use Cerner. I know you folk guys do too. And then typically what I would do is we would refer to either a hypertension management program, diabetes, parent education, the list goes on and on of the various consultants that we work with. So we decided to kind of put this up in a different way, to think about, in fact, enrolling patients in an ongoing texting campaign. And what we built in is logic that identifies only abnormals and looks at trends, and in fact, directly links to the patient, and whether it's an NP who's managing their hypertension, MFM who manages diabetes in our case, or parent education, that the doctor would be informed, but the doctor didn't need to be put in the middle of this discussion unless there was something that he or she needed to know about. So how does this work from a logistical standpoint? So we have become very intentional about getting a cell phone number for every one of our patients. And what happens is we've built in automated pathways that fire without, in fact, the provider doing anything. So the example is if I order aspirin on a pregnant woman, she will automatically be enrolled into our aspirin pathway. Similarly, if she is having a cesarean, if she gets scheduled, these texting pathways will start automatically. And we've also built in smart logic so they cancel. So the example of the cesarean, the woman who comes into labor who has a scheduled cesarean next Thursday, who delivers tomorrow, that pathway will be canceled automatically the moment that we put in a birth weight from that perspective. Just to give you a sense of kind of what these messages can look like, this is from our blood pressure component. And what you can see is we also have the vital signs that are face up to the provider if he or she wants to look at the trend from that perspective. So sort of broadly kind of going a little bit further about what we're doing with HIPAA compliant texting. And it really builds on the complex idea of campaigns. So recognizing that we want to touch patients in different ways at different time points, we're able to build out these campaigns that can be based upon timed events. Again, it's an automatic feedback loop, so I don't need to look at every blood sugar, I don't need to look at every blood pressure, but I only need to think about the abnormals. The other issue is we, and again, it depends upon the pathway, have built in the ability to escalate immediately via text to the provider for critical values. And the most common example where we see this is, in fact, is postpartum hypertension. The other point, and I'll make this point in a minute about the importance, is we're able to centralize dashboards. So rather than having me try to manage my small component of folks with postpartum hypertension, I can now make that centralized at one resource who can manage all of it. We've gamified it so the patients get a positive feedback loop. And again, we've recorded all of our conversations in EMR for better compliance in documentation. The only point on the right to make, again, this is Pew data, but it points out the median number of texts the patients that we care for utilize. So the average 18 to 29-year-old receives 40 texts a day. It's less than 30 to 49 years old, but it's still on average at 10. So this is what our patients are doing, and we thought it was important to us to be part of these conversations. So I'm going to start with postpartum hypertension. This is data that comes from the MMWR. And I think although there's been a lot of attention paid on hospital care, it's important to recognize that in fact, the most common time that a woman dies is not during her delivery, but really over half of women who die, it's due to the fact that she's had hypertensive crisis outside of our hospital and resulting in a stroke and a death. So in terms of US maternal mortality, it's shifted from our hospital to the postpartum period. And again, we see this profound black-white disparity, and I'll just give you the national number, which is 3.2 times the white rate. If you look at the postpartum deaths that occur, I've alluded to the fact that most of them are due to hypertensive crisis, and about 82% of them. And if you think about it, this sort of represents the normal postpartum physiology. So folks who are postpartum have tremendous amount of edema in their legs. These fluid typically enters the bloodstream, typically about day 5 to 7. And if you look at the peak time of readmission, that's when it occurs, and also the time the patients are least likely to be in our hospital. So when we started this process, we were very intentional about looking at data. And what we wanted to do is to look at postpartum hypertension as a readmission as a proxy about our ability to address this issue. And as a reminder, ACOG currently recommends that women return on day 5 through 10. And just going back to my picture of Karina, the complexity of getting a mom to come back to our offices in that time frame, postpartum, dealing with all the trials and tribulations of being a new mom. We know that only about a third of moms nationally, in fact, return for that visit, suggesting there's a huge gap in compliance. So I was fortunate a number of years ago to actually be the referee in a Philadelphia-wide contest that Addie Hirschberg first put out her work on postpartum hypertension. Addie actually did a prospective RCT as a fellow. For those of you who have not been to Penn in West Philadelphia, this is very much an at-risk, lower socioeconomic population. And Addie was able to randomize 206 women to either giving them a blood pressure cuff, along with a texting campaign or usual care and asking folks to come back. And one of the interesting points to make, out of the 9 women who Addie approached, 206 of them had a smartphone with texting capabilities. And what Addie found is that 92.2% of her patients, in fact, returned at least one blood pressure, versus if you looked at usual care, it was 43.7%. And what Addie was able to do is to drop her readmission rate to 0%, versus 4% in her usual care group. Although this wasn't significant, it was obviously thought-provoking. So being energetic and interested in this concept, we delved right in. So just to call attention, our baseline rate of readmission was 1.2%. We had a very profound racial disparity at the start of this. So amongst our mothers who were readmitted, 61% were African American. And we went ahead and launched this about 3 years ago now. And in our first 269 women, we were able to achieve what Addie had done, which was to get 91% of our mothers to give at least one blood pressure. Ironically, almost the same number that Addie got. And 70% of our moms, in fact, submitted 10 blood pressures over 10 days. The difference between Addie's experience and my experience was I managed to double my readmission rate. And it was statistically significant when we looked at it the first time. What we realized is in fact, we were letting our residents manage our blood pressures. We have 28 residents, and we had literally 42 different ways of managing blood pressures. So the second phase of this project is, in fact, we went and did a protocol. We put all of the care management in one nurse practitioner's hands. And rather than just simply reacting to blood pressures, this particular individual was given a protocol that utilized Lasix as primary treatment, and in fact, looked at trend rather than just extreme blood pressures. And our medication utilization went up from about 14% to about 30%. This slide's a little older. We've now done over 16%, 1,600 women. And we have now lowered our readmission rate from a baseline of 1.2% to now 0.54%, a 55% reduction. And what had been a racial disparity of 61% of our readmits being African American is now down to 31%, consistent with our delivering population. And we've now gone from the immediate first 10 days, which is the primary time that women get readmitted, to actually 42 days, and now transitioning these folks to our virtual care center. We're actually expanding this across the state and are working through the logistics of that. But we recognize that if we're able to do this, it'll probably result in a care savings to the state of about $312,000. So this is the one nurse practitioner, just to say that although it sounds impressive that she's managing 1,600 patients, what's important to recognize is what you mostly see on our dashboards are greens. The reds are people with mildly elevated blood pressures. And in fact, she does this about an hour and a half of her day of her job to manage a complex group of women, because she's not going back calling and faxing and asking for blood pressures, but just simply dealing with results. So we took the same concept about gestational diabetes. So again, it's long been known that there are significant gaps in getting women to comply with their 2-hour glucola. I don't need to tell this group that gestational diabetes is very common and that the majority of women will resolve. There was a change in guidance a couple of years ago that, in fact, a 2-hour GTT, though still the gold standard, could be some substituted with women giving fasting blood sugars a couple of mornings a week from that perspective. And we switched from that perspective, from asking women to get 2-hour GTTs to doing fasting blood sugars as the standard of care. We presented this, I think now it's 2 years ago at SMFM. This was the first 430 odd women that we took care of. And just to kind of walk through a little bit of the numbers, this is just looking at compliance. And what you can see, the blue bar, our ability to get women back for a 2-hour GTT was about 1 in 4 in our population. And this was done with actually a nurse whose predominant job was to beg, plead, try to find transportation for folks. Yet when we simply made it easier for folks to do it at home and to work with the tools that they've had, we were able to double our compliance from that perspective. So compliance about testing is good, but what we really wanted to make sure is, in fact, we were increasing the rate of women we were detecting with diabetes. So this is looking at that same cohort. And what you see is amongst the cohort, about 5.4% of our moms we would diagnose with diabetes with traditional 2-hour GTT. But when we went on to do text-based care, 12.1% of our population, in fact, now is being diagnosed with diabetes. And these women were all followed up with a 2-hour GTT. Going to the concept of disparities, these gaps were even broader when we looked at our Black and non-Black rates. So when we looked at that, folks who were able to comply with a 2-hour GTT, our rate of compliance in our non-Black population was about 28.5%, but was only 11% in our Black population. When we went to text-based care, there was a rising of all boats, and our 28.5% of our non-Black population went to 50% in text-based care. In our gap, which had been statistically significant, disappeared with our African American population going from 11% to 34.5% compliance. Still far from perfect, but this was an incredibly simple app where we just told women we were going to text them and ask them to send their values back from that perspective. On the right-hand side, you can see again, the more important number is that our rate of diabetes went up significantly in both groups. So amongst our moms with 2-hour GTTs, what you saw, only 6% of our moms in our non-Black population were diagnosed with diabetes, but we doubled that number with text-based care. And in our African American population, we went from a rate of 2.2% to now close to 14%, highly statistically significant, highly different from the population. So just to reach out to the broader literature about gestational diabetes and going beyond our personal experience, There have been a number of trials of what's called mHealth, and again, there are different mechanisms of mHealth. Some are texting, some are apps, some are just simply reaching out by smartphone. But as you look across the literature, there's a consistent closing of the gaps of compliance. And I've just chosen this study from the Gray Journal in 2018. This was an Israeli study. It was an RCT, which randomized women with gestational diabetes. And what you can see is women who, and again, this was an SMS-based platform, that compliance went from routine care of about 66% to 84%. When you looked at the mean glucose, it was significantly more in range with women who were in text-based care. And the number of off-target measurements were markedly lower, as well as actually the need for insulin across the board. Not surprisingly, in this small sample size, there were no differences in OB outcomes, but I think it provides further evidence that we can use mHealth to close some of the gaps in care that we see. So we've now pivoted to think about other things. This is lactation. We recognize that we spend a lot of time in paying attention to the quality marker, PCO5, about getting mothers to lactate. But when you delve into the literature deeper, what you find is most parents, in fact, start breastfeeding in the hospital. But as you look at time, there's an extreme drop off across the continuum of moms who will actually reach it to a year. We recognize that we didn't have a lot of opportunity to address this issue, as this was happening long after folks had had their postpartum visit, assuming that they had gone on to get that visit. So we took exactly the same approach. Again, this now fires automatically in all of our breastfeeding moms. And we actually have a 26-week texting program. The goal is to provide both education as well as to help do individual assessments. So for those of you in the pediatric world, this counts numbers of feedings, numbers of diapers change, and also the numbers of urination. And it has the ability to be monitored. So our lactation department actually monitors this. And what they do is if they see a person struggling, they actually just schedule a video visit from that perspective. I don't have outcome data yet because this has been one of our newer projects. We've actually enrolled about 1,500 moms in the first 6 months. We've had tremendous, surprisingly high response rates. So about 96% of our moms respond with the first text, with a surprisingly high majority of them continuing through. Our goal is to get to outcome data to know what percentage of our moms are in fact breastfeeding at both 3 and 6 months. But we're interested to learn more from that perspective. The only other point to make about this is from a process standpoint is we chose to make it a two-way text, meaning moms can send us selfies, they can send us questions. And it's been a very positive for moms globally. They're aware that we can't answer them immediately. And if they have an immediate question, to call their doctors. But we picked up a couple of infections as well as a couple of women who had other problems that we had not anticipated by making this a two-way discussion. I'm going to pivot now a little bit to a project that we've been interested in for a while. So low-dose aspirin, I think Dr. Wallace mentioned that I helped lead the aspirin trial along with Dr. Carlo and a number. But if you look at really what is the cost, the primary driver of perinatal mortality, it really falls into two camps. So preterm birth, and again, much of that is now due to either preeclampsia or preterm birth from that perspective. When you look at the cost of preeclampsia alone, and this is data from 2017, about 10% of our moms are getting preeclampsia. And if you look at the adjunctive costs of preeclampsia per birth, it's close to $6,500 from that perspective. And I think most of us are aware that USPTF recommends routine screening of women who are potentially candidates for aspirin to prevent preeclampsia. The graph on the right points out the effects of aspirin, and this comes from Daniel Rolnick's New England Journal of Medicine article. And what you see is a pushing of folks from the placebo arm to the aspirin arm of when they get delivered. So when you look at the data a little bit carefully, what you see is in fact there was no difference in the rate of preeclampsia amongst women who took aspirin. But what you really see is the shift from the time that they have it in the preterm birth period to then the term birth period. And in a subsequent analysis, they found that it was an average of shift of preterm preeclampsia by about 4.5 weeks, a tremendous cost savings. This is our aspirin trial. Again, this is a trial of nearly 12,000 women. Just to say this is not exactly on point with US experience and was done in low middle income countries. But just to point out that one of the benefits of aspirin is to decrease the rate of preterm birth. In our trial, we were able to reduce the preterm birth rate less than 37 weeks by 11%. But what's more important to me is we were able to reduce the rate of early preterm birth by 25%, rate of preterm preeclampsia by 11%, and very similar to actually the aspirin trial, we were able to reduce the rate of early preeclampsia before 34 weeks by 62%, and over perinatal mortality by 14%. And this was done at a cost of about $1 per woman. What was interesting about this trial, and one of the things which we came to recognize, is going back to that first picture that I showed of those ashas, those women who literally met with them every other week, talked about the importance of compliance and follow-up, that we were able to achieve incredibly high levels of compliance with the far and away vast majority of women taking the vast majority of their tablets with no differences in outcomes and adverse events. So the challenge is what we recognize is, in fact, when I went and looked at my own population, in fact, we weren't really that good. So we were not at 85%. We were somewhere around 30% as a system in terms of mothers who actually came in with risk factors for preeclampsia, according to the USPTF, who in fact were actually taking their aspirin. So what we recognized when we talked to our patients, there was a couple of things, one of which is many of our patients didn't understand why they were taking aspirin. They were taking it episodically for headaches or pain, but rather than thinking about it as a prophylactic. And then the other part of it is what I would call the grandmother effect. They would go home and talk to their mom or other people who said, we didn't do that, please stop that. So we built this pathway. It fires automatically every time there is a prescription for aspirin given for any pregnant women. And again, it completes at the time of birth weight.
Congrats.
So this is a comparison, and we sort of have a natural experience within our population. So we are a large birth hospital. We do about 6,000 births. About half of my half of prenatal care flows through my employed groups versus the other half through our independent groups. And this is going back several months when we first started this. And again, what you can see is the baseline was pretty consistent between the two groups. The top group being the independent providers who didn't have the benefit of a texting platform versus us who did. And what you can see is we've gone from a baseline of 37%. And for those of you who follow process control charts, this is actually demonstrating a causal effect, to now we're about 70% versus our independent providers are still hanging around in the high 30%. So we've taken this work and we've gone on to think about it from other processes. So thinking about it not just from how do we improve the outcomes, but how do we work on simple things like how do we get the patients to the right spot at the right time. So we have a cesarean induction as well as an induction pathway. It provides maps of where you're going to park, birthing classes, links to our app, talking about car seats. If anybody's been frustrated about the inability to get a patient out because of a car seat, it talks about those sorts of things. Our MPO policy also provides our anesthesia screening. And one of the important things is if you've implemented the ARRIVE trial, we've gone to actually now a model where our patients, rather than congregating in an area and getting angry as they're waiting for a nurse as 3 labors come in, they actually stay home until we can actually have a nurse and a bed to care for them from that perspective. And this has been highly successful in terms of patient satisfaction. So finishing up a little bit, just to talk about where we are in our journey. So I've spoken about our app, as well as our texting platform. Our goal is to merge the two of them together. So they're currently right now in two separate different venues from that perspective, and continue to demonstrate value to our system and capture the ROI. We also have put in for an FCC grant that we're waiting to work on. Currently, right now, our approach is our patients enter their glucoses and blood pressures. We're looking at some technologies to make that easier. We're also looking at artificial intelligence. So we have published a model on preeclampsia readmission. A number of folks are working on this as well. But thinking about how do we use artificial intelligence to think about patients who are at risk and then launching pathways based on risk scores. We've also started to think a little bit about different populations and ways that we reach populations differently. So the concept of psychometric segmentation or delivering messages to different groups of people in different ways we're taking a look at. So we're looking at gestational diabetes into Spanish. We're also looking at delivering different messaging to women who are African American about breastfeeding, particularly to our NICU patients, where there's significant opportunity to improve outcomes from there. And then finally, we're continuing to build the infrastructure. So right now, we've been able to sort of build this with a little bit of duct tape and baling wire to hold it together. The person who manages our hypertension is just simply we added onto her job. But as we work to build this to a statewide model for both hypertension follow-up as well as for aspirin, continue to utilize that to deal with some of our at-risk contracts for both our perinatal cooperative as well as our medical ACO. I will just finish by pointing out, for those of you who don't know what that object on the right is, it's called a SNU. It is an AI-informed crib. It costs $1,500 and you actually cannot buy one. Interestingly enough, they have shown that through the way that it's constructed and it does both noises and movements, that they increase the average mom's sleep by 2 hours. So artificial intelligence is now really coming of age and is everywhere. And I would be happy to go ahead and stop and answer any questions.
Hey, Matt, I'll go ahead while hopefully others join in to, speak up or drop questions in the chat box. This is just amazing, and thank you again for sharing that information. So this is one way to reduce disparities, all right, between communities, and it looks like with larger sample size, you may be able to demonstrate that. And I know that right at the level of Congress and NICH, they are looking for these kinds of interventions. My quick question is, after congratulations, is does this pay for itself currently, or you're doing it as a research project?
Yeah, so this is really inspired by, in fact, the funds that were put forward for the building. Our board put forward $10 million to do this kind of work. And again, it's a unique opportunity. Your question is an interesting one. So there are currently dollars for remote patient monitoring for both hypertension and diabetes. The other work like aspirin, contraception, breastfeeding, closing those gaps in care, funding doesn't currently exist in that. There is a bill called the Mama Bus bill, which is obviously a play on words for the omnibus bill, but designed to close some of the disparity gaps that we've talked about already, that has significant dollars for remote patient monitoring. I think the challenge is to demonstrate the ROI on these things.
Yeah.
And for us, as we're thinking about it, right now, about 10% of our contracts are capitated, not fee for service, but rather total cost of care. And that's where the value is, and particularly in the aspirin pathway. I don't know if you've looked at your internal finances, but currently I spend 58, every dollar I get to take care of for a mom and a baby goes to my friend, 58 cents of it goes to the NICU. So if I can push those 28 weekers to a 32 weeker, the cost savings there are tremendous. And again, as we're looking at total cost of care, that's the real upside for us.
Thank you.
Dr. Hoffman, thanks so much for being here today. We really appreciate it. Quick question about your postpartum hypertension surveillance. What type of cuff do you use?
Yeah, so we use an Omnipro. Alan has taught me about the virtues of the right cuff from that perspective. We actually just order them from Amazon through those funds that I spoke of. We've been able to supply them for all of our patients. We have looked at Bluetooth, and I think there's a lot of interest in Bluetooth-enabled cuffs. I'll say we got 91% compliance, and if you look at Addie Hirschberg, she's at 92%. So I'm not sure there's a lot of bang for the buck for a Bluetooth-enabled cuff. I think it's really about engagement.
Thanks a lot, Dr. Hoffman.
Wally, go ahead.
Yeah, Matt, that was exceptional, really good. And I love how you leverage to other conditions within OB and even in pediatrics or neonatology. I think that's fantastic. And it can be leveraged the same way into all of healthcare, reminding the group that actually the family gravitates towards getting care where babies are being delivered. So you can engage the father also, who typically have poor health-seeking behaviors. So on a more specific comment is that we were dealing with some of the similar issues of early after birth problems at home, not detected in neonatology, in pediatrics. Neonatology was an issue. And it was discussed at many levels. And a simple solution was that the American Academy of Pediatrics really required for quality of care, for meeting standards of care, require a visit 48 hours, within the 48 hours after discharge for the baby. And you could get the mother's blood pressure if they don't have a cough at home. You could get it through the pediatrician's offices. So it could be a really good thing if ACOG and an SMFM says that an appointment or a blood pressure check should be done, and it could be done through the AAP recommended appointments, and you could coordinate that all together and get the information and improve the care of our parents. And the big message of this, and it happened when the AAP recommended this, is that the mothers now know that the baby is going home, but it's not totally healthy, totally okay. They can forget about the healthcare system. They have to continue engage.
You know, I couldn't agree with you more, Wally. I might just push back a little bit to say, you know, the compliance with the 48-hour visit is probably not 100% either. And if there are ways to use this technology to bridge that gap, as women are having to drive further and further to get care, particularly in our rural communities, how do we think about that mom who now has to load her newborn, do the car seat, drive there, post-cesarean, you know, as many barriers as we can pull out and think more like an Amazon about radical convenience, the more likely we are to bridge that compliance. It's not an answer for everything. And again, we need to get more data. The data is early, but at least in our hands seems to be showing benefit.
Yeah, it may help us if you require the mothers to get their blood pressure. It would help us because we require them to get a bilirubin, which obviously has to be in a healthcare facility. But people are gradually have modified their practices, so this is now very possible in the US.
Yeah, no, I think the question, can an ASHA type person with a transcutaneous bili be substituted for a 2-hour drive? Just a thought.
Oh, definitely agree with you.
How has the introduction of this messaging system streamlined the other forms of communication between providers and patients? So it's been a positive. So the fact that we've incorporated into the EMR, the provider is now in touch and aware and not blindsided by issues. I don't know how your hospital works, but the delivery person is often different than the discharge person, different than the other. But because of the fact that it's strongly integrated into the EMR, it's gone much better. I think the challenges that we're having is thinking about the patient journey and not overwhelming them. So if you can imagine the diabetic cesarean mom who's breastfeeding, she could get, incredible numbers of texts. So we're trying to think through that part of it to make sure that it has a cadence and a little bit more of a consistent voice as we're going back through it. We sent out 8,000 texts to moms who were breastfeeding last month. That's a lot of text.
I have a question. So, a lot of times that what we end up when patients tend to like texting based platforms, right? I mean, because it's easy to do. And we have a patient portal. So every time we start talking about, well, we have this other platform, legal and the EMR is like, well, we want this in the portal, so you can't use the texting. So how did you overcome that?
Yeah, so we use a third-party vendor that is HIPAA compliant. But we've also made, and again, we get into this question for everything that we do. So simply telling a mother where to park in terms of a cesarean section now is recorded in the EMR. It's a little crazy, and that's part of the challenge of doing that. But because our legal department makes every conversation that we have recorded, now the flip of that is if we have a conversation from a patient and then our response, it's now automatically in the EMR. You and I probably have several conversations a day with patients or nurses that at least the synopsis may be inaccurate if ever recorded. So this at least captures that issue, and our legal department is actually super pleased with that component.
So Matt, you were so efficient. You gave us a lot of time for discussion. That's terrific. If you don't mind, I will go to Dr. Wallace, obviously, who is the director of e-medicine here, just to, Eric, if you don't mind just commenting for us, and maybe Matt can react to that on just what we are doing currently from an e-medicine perspective, but also from just research projects that we're doing. How does what we are doing, mirror what Matt is doing or differ from that?
No, it's a little bit different. So what we're doing currently in UAB medicine, so we're monitoring about 380 patients concurrently. We have admission criteria and graduation criteria, so we don't monitor them forever. But our average blood pressure reduction is about 9 millimeters of mercury in the first 60 days. And remember, these are patients who, in order to qualify for remote patient monitoring, you have to be uncontrolled, seeing a doctor on 2 meds. So Alan, you asked me if we had a control group, like a standard of care, but all of these patients failed standard of care because they were uncontrolled on 2 meds. We get them on RPM and they have a 9 millimeter reduction. Same with glucose. So we have insulin requiring diabetics. A1C greater than 9 is our current. That can easily be reduced, but we see a reduction in their glucoses because we have nursing staff that actually calls them. So our system right now is Bluetooth. Most of the reason that we started with Bluetooth was that Medicare, which was the only reimbursing agent, required Bluetooth, and our UAB legal didn't want the possibility of errors when patients put in data. But luckily, I think Medicare, January 2022, has introduced remote therapeutic monitoring codes, which does allow for manually input data. And I agree, it's a lot cheaper. So currently our costs are around, when you include the nursing staff, sorry for the background noise. So when you include the nursing staff is about around $100 per patient per month. So it's pretty expensive, but we get reimbursed and actually end up making money on the Medicare side. On the other hand, when you start talking about these value-based care where we are the ones paying for it, it is not fee for service, then you say, how can I reduce the cost? And clearly having the patient input their own data takes it from $100 to pennies, because you just have to deploy an app and they put in their own data. So I think those are, definitely considerations. We are in talks with Medicaid about covering this, both for the OBGYN patient population as well as others, because our currently Alabama Medicaid does not cover RPM. And it is a huge portion of our pregnant females and diabetics and hypertensives, CKD patients, et cetera. So that's what UAB is currently doing. And like I said, we have FCC dollars available. We got the $1 million FCC grant during the COVID funds. 300,000 of that is devoted to remote patient monitoring. So we can actually, despite the fact Medicaid doesn't cover it, Blue Cross Blue Shield doesn't cover it, we can do it at UAB for free until the money runs out. So happy to partner with folks to give this a try. What Rachel and I were trying to do is to validate the blood pressure cuff, because our current vendor did not have a blood pressure cuff that was validated in the pregnant population. But unfortunately, just as studies in technology usually go, is the technology changes faster than the study can happen. So we were in the middle of the study and the company changed blood pressure cuffs, and all of a sudden we had to change gears. So we do have a blood pressure cuff, but it's not been validated in the pregnant population. But I think where a lot of folks have started is in the postpartum, monitoring. That's where UPMC started. It's where Ascension Health is starting, because of the mortality rates, because it's only usually a 1 to 3 month monitoring period. So it's a very defined timeline when people are doing the post monitoring, but that's what we currently have in place.
Thank you. Matt, any reaction? And then we'll get Dr. Andrews' question. Matt, any comment?
Oh, no, I think, part of it is this is so new, and the publications are limited. So, you have the UPMC experience, the Penn experience. I think a lot of us are rushing into this. I do think we need to be wary about technology for technology's sake. So we need to show outcome differences. So, we've been very intentional about following data, making sure that we have baseline data and that we're changing the outcomes, because eventually, as we're going to ask the payers to do that, that's what they're going to ask for. I think the other part of it is partnering from industry. Industry says that they can do everything and cure cancer with a map. We need to be really cognizant of that. If you talk to these folks, they typically don't have a strong medical background. They usually have a group of advisors. So I think we really need to hold them to account or be active participants in the discussions. I think we've been wary about doing that, but this is the way the world is going and changing, and we need to be part of that consideration.
Yeah, I think, the other studies that I've read as far as paying for this has really been in the ability for an OBGYN to reduce, specifically in the capitated payments, because I don't see Medicaid paying more for remote patient monitoring in the prepartum space under this capitated model. But where some groups have implemented remote patient monitoring is even under the capitated model, as long as it's cheap to do so, is to reduce the total number of visits that the female has to come. So you could actually take care of more with less staff, because you don't have to bring the patient back every 2 weeks to check a blood sugar.
Great. Last question to Dr. Andrews.
Well, mine is simple. First of all, I would say, based on the comments just made, that there are only 2 places in the state that do obstetrics that are fee for service. Everything else is capitated, and that's Medicaid's decision. One of those fee for service places is UAB. The other question I had is pretty simple, and it's for Eric Wallace. I I understand that legal might be concerned about errors that a patient might make in entering their own data, but are you aware of any data that actually documents what that error rate really is? I mean, if it's low and if it makes it so much more affordable, it seems to me that we ought to pay attention to that. Or if we don't have those data, maybe we need to generate them.
Yeah, I think it's very easy to generate. And I think that now that there's a reimbursement strategy, there's more reason for us to push on them to allow us to do it. I mean, we have this data all the time and the patient faxes it in and then we scan it into the chart, right? So we're doing this, we're just, I mean, it's just not electronic. I think what our experience is, because we have done a handful of OBGYN patients, which is, it's not, you know, the complexities of instituting remote patient monitoring are not just in getting the data. Probably the biggest complexity is what are the appropriate alert values? What do you do with those values? And I think that we had one example here where a patient got called so many times because of the alerts we had set that they were very dissatisfied with remote patient monitoring because we called them too much. So I think what we're trying to do, and really where I think a lot of this feeling out has to be, is we almost need to institute something, learn from that as far as what are our thresholds for calling the patient, for initiating or for notifying the doctor. What do we want the nurse to do? So it's planning the whole program that is probably the more complex part than how do I get the data in.
Yeah, just to correct what I just said, that capitated fee-for-service rate only applies to Medicaid funded patients. All the private insurers are capitated as well.
Right, well, terrific. So thanks, everyone. Thank you so much, Dr. Hoffman, for making this, Dr. Wallace, for a really terrific discussion. And this issue is not going away. So all have a great weekend, and we'll turn it back to the program for the next item. Thank you.
Take care. Thank you.
Thank you.